A very good afternoon, everyone, and good morning, good evening. So, wherever you're from, it's a pleasure to have you here. Uh, this is one of its kind webinar series that we have at an international level from the Hypertension Core Group of IAP in India in collaboration with the International Society of Hypertension, the South Asia and the Central Asia Regional Advisory Group headed by Dr. Azra Mahmood, the World Hypertension League, as well as the Pimpri Chinchwad University. Uh, we are here today to discuss lifestyle management, but this webinar series would focus on lifestyle management, the pharmacological management, salt as a precursor for hypertension, and how we can overcome it, along with some traditional medicines from the South Asia and Central Asia region. We welcome all, I'm sorry, we welcome all of you here today to be a part of this and to take this forward to take forward the the challenge that our region faces from the South Asia and the Central Asia. uh, Extremely important. I think we'll understand as we go through this webinar series the importance of managing hypertension, understanding and preventing it today. We do have we will be introducing IPN and ISH, the South Asia, Central Asia region today. But before I do that, I request all of you to kindly keep yourself on mute and the videos off during during the webinar. At the end of the webinar, we'll have the questions for everyone to ask, and the speakers, I'm sure, will be very happy to answer if you have any questions. Swati, can we have the next slide, please? Um, before I introduce any the whole webinar, I'd like to introduce our moderator, Ms. Datta Patel, who's the HOD and Associate Professor for the Nutrition and Dietetics Department at D.Y. Patil School and Medicine and Hospital in Navi Mumbai. She's also the National Executive Member for IPN India, as well as the Joint Program Officer for Nutrition and Diabetes Core Group. She's the Associate Editor with the Clinical Nutrition SPEN Journal, as well as an editorial member with D.Y. Patil Journal of Health Sciences. She's a PhD scholar for food science and nutrition and has been awarded multiple awards across her long-standing career of almost more than 20 years. Datta, has she been able to join? I think she was facing some technical issues. Swati, can we have the next slide, please, till Datta joins? Before I introduce the ISH Saka, I'd like to introduce the president of IAP in India, who is Mr. Shiv Shankar. It's a pleasure to have you here, sir. And Mr. Shiv Shankar is the chief dietitian with Tata Memorial Hospital, as well as the vice president with the Asian Nutrition Society. He's the chairman for the IPN Quality Awards, and as well as the head of advisory committee for Poshan Dhara Association. He's a research consultant with NIRRH and an instructional designer for Onco Nutrition course by BMN College, Mumbai. He's also an assistant editor with the Journal of Nutrition Research and has multiple book publications and is one of the leading I think onco-nutritionists that we have in our country. Over to you, Shivasa, and hoping to hear a few words from you. Swati, if you could stop sharing the screen for a minute.
Thank you, Mansi, for this invitation and for the introduction as well. At the outset, I would like to congratulate International Society of Hypertension, World Hypertension League, and Pimpri Chinchwad University for this joint collaboration. However, I learned during your introduction that there were some more stakeholders. Sorry, I couldn't get those names. So this is just a step what you people have taken towards addressing the hypertension issue. uh, I do understand that when it comes to the hypertension goes hand in hand almost with diabetes. But diabetes has been spoken very widely, and at almost every forum we have some sessions being addressed to the diabetes. But somehow hypertension gets neglected in this process of addressing the health issues. But what you people are doing really wonderful work, and I congratulate each and one of you for taking this initiative, because diabetes awareness is already there, I would say, per se, but hypertension awareness is still lacking over there. However, everyone knows that this is also a kind of a health risk, but people are not that aware of getting screened and getting into the kind of an understanding what kind of complications it might arise if it gets neglected continuously. So I'm not going to take much time over here because there are many experts who are going to speak, and in fact, I am also waiting to listen to them. And I just conclude saying that wishes to all, good wishes to all, and delegates. I hope you'll be having enriched kind of a sessions. Thank you so much once again, Mansi, and all others. Thank you.
Thank you for kicking off the webinar series, sir. Swati, can we have the slides again? So the ISH Raga, the ISH RAG, that is the Regional Advisory Group, South Asia and Central Asia. Um, it it's a special interest group for a specific group of countries. Swati, if you could have the slides, um, where uh, the aim is to have policy advocacy, educational trainings, to talk about what the present scenario and what the prevalent conditions in this region. I think it's actually very important to look at the problems that we face in our country with our perspective, or our region from our perspective. This is being ably led by Dr. Azra Mahmood from Pakistan. The members for the RAG today, Swati, if you could go back. The members here with the for the webinar series are Dr. Azra, me, Dr. Varun, as well as to Bhartikar. But the other members, um, Swati, I think you've reached the last slide. If you could go back. The other members are Dr. Thusra from Sri Lanka, Dr. Mahmood Haroon from Afghanistan, Dr. Amrit from Nepal, Dr. Sange from Bhutan, and Dr. Solat from Pakistan. It's an absolute pleasure, and I am really glad to see Dr. Hind as well joining us from Sudan for our session today. I think without much ado, we'll go to the next slide and we'll look at kicking off this webinar series further. Our first speaker of the day is Dr. Azra Mahmood, again, extremely knowledgeable and with a very vast experience in hypertension. She's the chair of the South and Central Asia Regional Advisory Group of the International Society of Hypertension. She's a physician, scientist, and medical educator, as well as a hypertension advocate. She's the director, Department of Clinical Research, Shalimar Institute of Health Sciences, Lahore, Pakistan, and a consultant hypertension and internal medicine at the same institute. She's also a fellow of the American College of Cardiology and British and Irish Hypertension Society, and she's got more than 100 peer-reviewed papers and an H index of 34, which is absolutely amazing. And it's an honor to have you, Dr. Azra, here today with us. And I hand over the podium to you to take us through your session on what the challenges are for our region and set the context for hypertension management and lifestyle management for South Asia and Central Asia region. Over to you, Dr. Azra.
Thank you very much, Mansi. And I'm going to start the task of sharing. So best of luck to me here. And so next I have to have this, I think. Let's see.
The share
let me know
screen button at the bottom.
if it's working. Let me know.
Yep, it is.
You can
yes.
see the slide?
I can see the
perfect.
slides, yes.
Okay, without further ado, thank you very much, Mansi. That was a very heartening introduction and also introducing Saka. It's a pleasure for me to be here at this webinar. I think it's an excellent opportunity to talk about lifestyle in hypertension in our region with a specific context. And I would also thank all the panelists who are joining today. Hopefully it's a good session for you. So I think we all know about hypertension. It's we call it very famously as the silent killer. It is obviously the leading risk factor for cardiovascular disease at the moment, if you look at the global disease report. What is very alarming is if you look at the data, which the WHO report published just now in this 2025, we can see that we have a huge burden of undiagnosed hypertension, almost 600 million. But even if we look at the cases who are diagnosed, our control rates barely reach 320 million. So even when we detect it, we are not really doing a great job in terms of controlling hypertension. I'm showing this slide just to highlight, if you look closely at the graphs here, um, the deep maroon areas represent uncontrolled hypertension and the blue represent controlled hypertension. If you look at the Southeast Asia region and the Eastern Mediterranean region, you can see we're doing fairly badly in terms of a high burden of uncontrolled hypertension and very low level of controlled hypertension. And of course, this leads to the question about the cost to families, health systems, economies. Overall, 23% in the world reach hypertension control. We have 4 countries like Canada, Costa Rica, Iceland, Korea who've done well and they've achieved high control rates, but these are very unique countries and who have put in very interesting interventions. Pakistan, unfortunately, in this report has superseded all the rest, exceeding almost more than 40% of uncontrolled hypertension. We all know about lifestyle being important for cardiovascular disease prevention, and I'm not going to really go into a lot of detail of that. The earliest study was at the Framingham, as you may remember, but started in the 1940s, which showed behavioral factors like smoking, obesity, hypertension, diabetes were long-term risk factors for cardiovascular disease. The InterHeart, as you may remember, was a cross-continental study where they looked at an risk of acute MI. And almost 90% of this acute MIs could be explained by modifiable lifestyle factors. And other studies like the Nurses' Health Study also confirmed that. The PURE study, as you may recall, was again even bigger than the InterHeart, and that includes a diet kind of very similar to the DASH diet, and that again showed the same pattern. So we have really a huge amount of evidence now to link poor lifestyle with cardiovascular disease. I think the biggest question that's usually comes to mind, because if you look at our diet, and I love showing this, especially the South Asian diet on the right-hand corner of the puri and halwa, etc. These are very high-fat diets, and we consume it for breakfast. But most of the time, over the last 30, 40 years, there's been a lot of experimentation with the Atkins, the Dukins, the Zone, the Weight Watchers. We moved on to the DASH. And it's been very difficult to really see any diet that worked better than others. The DASH diet obviously is what's recommended in our international guidelines, and this data comes about 30 years ago, which was the first paper that showed that the DASH diet was associated with the lowest blood pressure levels. Over the years, we have seen any other studies. The Mediterranean diet, of course, is very similar to the DASH diet, and that conclusively showed that there was a significantly reduced risk of a new cardiovascular event, whether we look at acute MI, stroke, or death, comparing to a standard diet if we consume this particular form of diet. The PURE, as I was talking to you already, it is unique because it was conducted in 6 continents across 80 countries, which include our region as well. And again, very similar to the DASH diet, a cohort design, almost 8 years of follow-up, very conclusively showed an 8% low risk of death and a 6% low risk of major cardiovascular events if the score of PURE diet intake was high. I think what I really want to talk for a few seconds is, why is that that despite all these dietary interventions, our obesity levels are high, and with all the physical inactivity? And I think the reason probably is, while our genetic milieu hasn't changed, our environment has. If we go back to the hunter-gatherer era, thousands of years ago, humans adapted. They did not have a lot of availability of food. So if you think about the thrifty gene hypothesis, nature evolved us to hold on to fat. And while these people were eating in a famine, feast kind of pattern, so sometimes they had something to eat, sometimes they did not, it resulted in maintaining a healthy body weight. And if we go to the Amazon now, we will see the same kind of pattern. Unfortunately, with the urbanization and access to a lot of food, we are keeping on a lot of fat and a lot of calories in, despite having the same genetic makeup. Of course, the biggest issue, I think what really irritates us, is a lot of public transport, a lot of cars, and we are not really exercising as well. I'm not going to talk much about it because I know my colleagues are going to discuss that in more detail. But we have a very clear correlation between level of physical activity and, for instance, coronary artery disease risk. As the exercise intensity goes higher, we can see over here, depending upon what exercise type we're looking at, the higher the exercise intensity, the lower coronary artery disease risk. And again, this is more recent data showing that physical activity and risk of coronary artery disease are significantly related in terms of the amount of physical activity performed in terms of the quintiles. So it is a very clear correlation. What has recently become obviously very topical and has been included now in the lifestyle modification guidelines is our mental health, our sense of well-being. And this was also shown in the Inter-Heart study, where the psychosocial index and risk of acute MI, as you can see on the right, was associated with increased risk of cardiovascular disease. So mental health as well as sleep are also very strong lifestyle risk factors that we really have to consider in hypertension. How does lifestyle actually lead to hypertension or the milieu of hypertension or high blood pressure? I'm not going to go in detail of that, but we have a lot of theories. One of the big ones is vascular inflammation, RAS activation, the autonomic nervous system gets activated, our endothelial doesn't function that well, and oxidative stress. And this has been shown in a lot of studies, and we know that vascular inflammation, if treated, can lead to reduction in cardiovascular disease. So really, cardiovascular prevention tied to lifestyle modification is really no-brainer. So if you look at the current International Society of Hypertension, or ESH, or American Heart Guidelines, lifestyle modification forms the core component of that. So along with measuring blood pressure, diagnosing, evaluating the response, and looking at risk stratification, lifestyle modification forms the core group. And if you look at the left-hand side of the slide, we can see that lifestyle obviously consists of a lot of factors. So it is not as simple as done, but it is something that we have to consider very importantly, not only in people who are newly diagnosed, but also those who are on treatment. And I think Mansi is going to talk about salt and other things as well in terms of how we can control hypertension. But this is, again, standard data that's available now, that interventions like weight loss, healthy diet, reduced sodium intake, reduce alcohol intake, and aerobic exercise, they're all associated with very tangible, very significant blood pressure reduction, regardless of the level of blood pressure, whether it's normotension or hypertension. So lifestyle intervention does work. And that is the reason it's a class 1 recommendation in all the international guidelines. And again, I would like to add again, even when we put people on antihypertensive treatment, lifestyle modification is something that goes hand in hand at every step of the way of this pyramid. And the lifestyle guidelines are there, I think, for people to kind of appreciate, so I won't go into a lot of detail of them. I think what I really want to take a few minutes to talk about is our region. If you look at what we should have and what we have are very different realities, right? So the lifestyle advice in our region is a problem. Why is that? If you look at all the developing world, it's a war-torn region, highly unstable, with high defense budgets. We also have a region where we have zero spending in terms of healthcare if you look at the total GDP. So we are the only region where we don't spend more than 5%. We are also the region where the high out-of-pocket spending in terms of patient population is. So in this kind of environment of healthcare, how would lifestyle be a priority? I would also like to talk about the role of physicians. Our physicians, there's a lot of private practice, and they don't have enough time to really talk to patients about lifestyle modification. This is not really the priority. And this is some data that we recently gathered conducting the World Hypertension League survey. And if you look at the middle panel, knowledge on recommendations, the knowledge level of physicians and nurses in terms of recommendations for salt intake, exercise, and daily intake of fruits, vegetables is less than 20%. So there is a huge gap in terms of physicians and healthcare providers. At the same time, also the problem is our patient population. Again, this is an ongoing study we are conducting, and we have almost 2,000 patients. And what we found that more than 80% of patients do not adhere to salt, diet, or physical activity recommendations. And so all the rest of the things we are doing are not going to have any impact if we are missing this major point. So why does lifestyle advice fail? We have the clinician issues, limited time, less generic advice. Patients have financial, cultural, environmental barriers. So you cannot really prescribe a salad where only bread is affordable. So poverty and food insecurity is a huge issue, as well as the climate change is also making things a lot worse. So these are the grassroots realities that I released in my title. We don't have healthy diets in the schools or at workplaces. We are sitting a lot. We have lack of urban spaces where people can really go and do exercise. And there's a lot of poverty that we have to deal with. How can lifestyle be a priority? If you look at the green space allocation, it is very clear. If you look at the green dots, this is the global south and global north. You can see a lot of green space availability, which has remained stable over time. If you look at our region, which is global south, you can see a lot of red dots. This is where the green spaces are diminishing over time. So we are losing a lot of space for exercise and walking. So all this recommendation of 30 minutes a day walking is really just saying things when we have no sidewalks, no straight streets, there's polluted air, and there is oppressive heat. How are we going to tackle that? The problem is the shrinking urban green spaces are because of the real estate expansion. They don't match the health needs, and there is lack of government oversight. So the walking shoes paradox is a big issue in our region, especially in hot climates. And I'm sure it also applies to continents like Africa. And how do we deal with that? So I think apart from just talking to patients and talking to clinicians, we need to look at policy reforms. So these are the grassroots strategies that will work. School food reform, work on children, building healthy habits. Urban planning is very important. So this is where the government comes in. Food policies, community gyms, areas for women to exercise. So you need to have the policy to translate into health systems, to translate into better health for patients. There are countries where they have done a lot of reform, like China, where they have many regions have lots of reduction in salt intake with a reduction in stroke. Singapore has done a huge amount of work in terms of ensuring WHO guidelines of at least 9 meters square of green space. Finland have done a lot of work in the school menus and any other interventions similar in the UK. So all these countries, and recently in Pakistan as well, the Punjab government has started some work in terms of nutrition program, and we'll see how that works. So I think if this, we have to look at the targets, but we also have to look at realities. If we don't enforce the laws, if the governments don't take ownership in terms of putting all these interventions in, our lifestyle advice that we give to patients every day in the clinic is actually going to go nowhere. So green spaces, healthy diet, but endorsed by the government, policymakers, healthcare is very important. And I think we need to try at the same time, give a lot of education to our patients about healthy lifestyle, as we are trying to do all the time in our clinics and our community camps. We're taking all this information to people. But the other thing we've started doing is creating citizen scientists. So we've taken this project where we are educating a lot of our patients to go in the community and give this information to other group of patients, explaining them to the science. And this has become actually quite a very significant and important project. And I think finally I'll come to the end and say we are in the era of artificial intelligence. If our physicians are not very good at giving healthcare advice, and if our other healthcare providers don't have the time, we have chatbots now. And the recent study by American Heart Association showed very clearly that in the over 65-year-olds, the blood pressure control rates improved significantly when they introduced the chatbot model in terms of lifestyle advice and adherence. And there are a lot of studies now to show that AI can make a big impact when we want to introduce lifestyle modification and taking a lot of the burden away from the healthcare providers. So it is going to be an exercise where all the providers, patients, payers, policymakers, population have to work together, just like Formula One. It is not a one-man job. And I think that's where something that we really have to bring to home. And this is my kind of lifestyle, I wish, I don't know if it will ever happen, but the present situation is that we have a model where tertiary care is the biggest chunk where the healthcare spending goes. We need to flip this pyramid where the primary and primordial prevention is the biggest chunk, and then we spend the least amount of money in tertiary care for reactive healthcare services throughout the lifespan. So from guidelines to grassroots, I will just say that we need to shift it away from an individual responsibility to a collective infrastructure and policy, and we need to look at equity lens. Healthy choices need to become the default, but as I said, it has to happen in terms of a policy shift. So it is not just about willpower, as we keep telling our patients. It is about the environment, equity, and systems that give us those opportunities. So I would like to just end with this message. When will we start advocating lifestyle change in hypertension? And I think for our region, we should lead and not lag, because time is running out as our hypertension control rates are really dismally low if you compare to the rest of the world. Thank you very much.
Thank you, Dr. Azra, for such a wonderful session. And in such a short time, you have almost covered all the highlights of the talking. So thank you so much for your wonderful session once again. And without much delay, I would like to introduce our next speaker, Dr. Mansi Patil. She is a faculty at Maharashtra University of Health Sciences and also faculty at Victoria University, Australia. She is also office bearer at the lots of international society like ISH, committee chairperson at the American Society of Preventive Cardiology. She is also founder and chief program officer, Hypertension Core Group app in India. And Mansi is a recipient of so many global awards. Outstanding Women in Hypertension Research Award at International Society of Hypertension, Colombia, and Sadhana Awards for contributing in the community nutrition, and also malnutrition expert at UNICEF trained taught programs. So she has a publication in peer-reviewed index journals, more than 60. She has published a book, and she's also co-founder at TrackWest Solutions. So without much delay, I would like to invite Dr. Mansi Patil and requesting her to start her session. Over to you, Dr. Mansi.
Thank you so much, Data, for introducing me, and thank you, Dr. Azra, for the wonderful session that you had. Are my slides visible?
Yes, we can see your slides, Mansi.
Great, thank you. So without delaying any further, I think I'll proceed with what I'm supposed to talk about, that is salt, spices, and hypertension. I think this is a very unique scenario for the South Asia region, but we will explore what happens internationally as well. So we'll talk about what and how salt impacts, which Dr. Azra has already done in short. And we'll also look at which spices and what are the biological effects of spices that we have. So today we see the average salt intake has gone up considerably in the past 3 decades for the South Asia region. We do realize that the average intake of salt varies anywhere between 8 to 10 and even at times 12 grams per day for an individual, when the recommendation is just 5 grams by WHO. So yes, excessive salt intake is something that we need to think of. And of course, there is a challenge in reduction, because we will need to talk about behavioral therapies and the behavioral advice that we give. Now, it's not just the taste of salt that plays a role here, but we also land up realizing that once the salt intake goes up, it's a very addictive taste, and so it's unlearning the taste of salt that is what we need to focus on. Sodium in itself, just a very quick brush up, will impact the sympathetic nervous system, the endothelial glycocalyx, as well as the RAS system, and the effect will be retention of water, sodium, vasoconstriction, and increased blood pressure. Ultimately, the baroreflex is increased. And therefore, it becomes extremely important to talk about salt, but we need to remember that both extremes are a challenge. So the mortality is high for even a very low salt intake or a very high salt intake. So it is a small range within which we need to maintain our salt intake. But why has it been such a huge challenge to reduce salt? I think that is a question that has come up multiple times, and where we've all struggled, be it clinicians, the allied health professionals, absolutely everyone. So I think one of the major reasons is the sensory preferences that we have developed. So over a period of time, we've got accustomed to higher tastes of salt, and therefore anything that is lower in salt, or let's just say saltiness, becomes a very hard sell. And thus the industry has shifted, the food industry has shifted very heavily on salt. It is a preservative, it's one of the best preservatives, but the challenge is, the uh, higher the salt or higher the saltiness is what translates to probably better tastes as we perceive it today. Now, will spices really help? So yes, whenever there's been a shift from salt to spices, we've seen that there's almost a 33% reduction in stroke, 56% reduction in cardiovascular endpoints, as well as 44% reduction in all-cause mortality. So salt substitutes really do help. I think there are no two ways about it. There's no confusion. But the challenge is, how do we do it? Uh, what are the ways to go ahead with substituting salt and with spices? Now, one, sensory substitution is a way forward, which means there are a lot of plant based substitutes or seasonings that are there which mask the taste of salt. So something like garlic or cinnamon, they have their own individual effects. That is those are the indirect antihypertensive effects that we are looking at, but they also mask the taste of salt. So you don't really crave for so much of saltiness. Beyond that, what we need to consider and remember is there will be drug nutrient interactions, but unfortunately we do not have a lot of large scale studies supporting the same. Now, when we talk about spices, is it just the South Asia region that benefits from spices? So I'd say no, this is just a very small snapshot of the various countries where there are numerous kind of spice blends that exists. So be it France, be it Ethiopia, Japan, US, China, Morocco, we all have different spice blends that are there. India may boast of garam masala, whereas China has the Chinese spices or the jerk seasoning in Jamaica. These are all flavor adding spices which enhance the taste of food, which enhance the palatability, and can actually help us in reducing the amount of salt that we use. So therefore, whenever you introduce a strong flavor, you mask the flavor of salt. So what happens is we are changing the saltiness signal that goes out to our brain. We are also overlapping the taste interactions that are there, as well as we are sending multiple we are sending out multiple uh, signals to the brain and our body which help in reducing the taste of salt. We also realize that there are certain types of salt, that's the research that's coming up, which says that you can change the construction of you can modify the formulation of salt itself. So those are nanopeptides that come in and which reduce the amount of sodium, but will still have the same amount of saltiness. But like Dr. Azra mentioned, we do have a very huge burden of the physician inertia that is there. That's the therapeutic inertia, where almost 81, there's a research by Dr. Zhang which says that 81% of the physicians have not prescribed a low sodium salt in their practice, and 86% of them are not even aware of the brands that are offering low sodium salts in their region. Now this becomes a very major challenge because it's not just about herbs and spices, but also the salts which replace sodium with potassium. So 25% of sodium gets replaced by KCl, and that again is what we call as low sodium salts. So the awareness and the prescription frequency is pretty low. Now, shifting from salt to, let's say, spices, be it garlic powder or onion powder, nutmeg, lemongrass, ginger, basil, bay leaf. These are all spices which will help in reduction of the taste and taste for salt. So what do these spices really do? Now there are n number of studies that you'll find, but these are all smaller studies, unfortunately. But yes, there are certain experimental studies, most of them in rats. One of the most commonly done study is in curcumin, which is turmeric, which talks about reduction of blood pressure with intervention with curcumin. Almost 40 grams per 40 milligrams per kg body weight of curcumin was given to rats, along with 20 milligrams with piperine. Now the result what we saw is, if curcumin is given individually, that is what has the most protective effect. But unfortunately, the bioavailability of curcumin becomes better when we are giving it piperine. So it becomes again very important to try and see where or in which set of patients are we going to use this. Now, there are other spices, let's say garlic, which is one of the most commonly prescribed or conceived as being very extremely helpful. Now, this acts as an ACE inhibitor, and it increases the nitric oxide production. Therefore, it will reduce peripheral resistance and leads to vasodilatation. So there are studies which say almost 1.5 grams per day of garlic powder will reduce the systolic blood pressure by 7.6 mmHg over a period of 24 weeks. So, but we also realize that the continuity of consuming garlic powder, of not increasing the salt, is where the challenge is. So compliance is a challenge. I think one of the best studies was done in UK for salt content, where what they've done is they have the food item itself. There's been a lot of promotion of the spice blends, as well as they've been consistently reducing for the past 20-25 years the amount of salt that is added to the bread. So the population doesn't really actively realize that the saltiness has gone down. It is such a slow reduction. If you see here, I've got the results till 2021, where almost the 71% of the breads did achieve the targets. Now up till 2020, 2010, the target was to get it down to 1.1 gram per 100 grams, and by 2020 the target was to to get it all reduced to at least 1.3, and which is what they've achieved. And the population hasn't really felt the change in the salt content. Now that just means that you know it is a cumulative effect. We will need public health policies. We'll need to rope in the food manufacturers as well. Now there are loads of herbs that we can use in our practice, or we can look at practicing, be it garlic, curcumin, piperine, or grape or saffron and herb blends. It's just that oregano, rosemary, thyme, and basil have very few RCTs to support their use. Saffron has very inconsistent evidence, but what is very strongly recommended is garlic, curcumin, as well as certain hot spices, which will lower the mortality for for the consumers consuming these studies, these herbs. I'm sorry. There's a small case-based scenario that we had. We roped in about 30 families, and we tried to give them certain herb spices. Now, what we realized was that there was a vascular structure change, and these 30 families were given the spices, which was turmeric and chili blend. And there's a small calculator that we introduced, and we taught them how to use the salt calculator to capture the monthly intake, and our endpoint was simply blood pressure. The results at the end of 12-week program, that's about after 3 months, is where we saw that the salt intake did go down by almost 18%, and the blood pressure reduced, the systolic reduced by 3.2, as well as diastolic by 2.1 on an average. The acceptability was 75%. So this all sounds very good, but the challenge or the implications are that it is not sustainable. So as soon as the festive season hit, everyone shifted back to the regular salt, and the spices were not used. There was a huge burden of salt that was contributed from pickles and papads and packet snacks, which we were not able to reduce. And probably the way forward will be to have a very regular use of salt calculator, a very having mobile integrated or AI integration of the salt calculator, so that there are reminders, and of course an honest reporting, which I think that's a very big challenge. There are other salt reduction strategies as well. So one is, of course, the salt substitutes. The other is, as I was speaking, the changing in the shape and the structure of salt itself. The challenge here is that it is very high preparation cost, so the application at a public level becomes difficult. The food processing innovation is what is required. So um, again, the development of this technology is expensive, but we can look at a more comprehensive way forward, where we are talking about introduction of different policies at a national and at a global level to reduce the salt. So what we realize is that plant seasoning is the way forward, probably a very promising strategy in a day-to-day practice, but it requires behavioral changes, and the adaptability and consistency with it becomes a challenge. There are studies by Dr. Cobb, I think that's Dr. Apple and Cord, have done fantastic studies in this region, where they've realized that until and unless the FDA regulation doesn't come in, the public health impact remains low. So public education, the dietary counseling, food labeling, all of these, the implementation is possible, but the impact remains still low until and unless we have regulatory mechanisms in place. Before I end, I'd like to invite you all tomorrow and day after for the rest of the webinar series on indigenous traditional medicine, as well as salt calculator, as well as the pharmacological management that we have on 30th. Thank you all, and one sec, let me stop. Yeah. Thank you all, and over to you, Datta.
Thank you so much, Dr. Mansi, for taking us through the spices of life and showing us the scientific evidence and case studies for the same. Moving to the next sessions, I would like to introduce our next speaker, Professor Varun Kumar Bedi. Sir has a certification of American Nephrologist of Indian origin, clinical nephropathology certificate. He is also MPH in epidemiology at Harvard T.H. Chen School of Public Health. Sir is a professor and head department of nephrology at Dr. Pinnamani Siddhartha Institute of Medical Sciences, Vijayawada, Andhra Pradesh. He is also a member Regional Advisory Group at South and Central Asia, ISH. He is a member ISN and the different wings of Collaborators in Advancing Clinical Trials Network. He is executive member at Andhra Pradesh Society of Nephrology. He is also a fellow of International Society of Nephrology and fellow of American Society of Nephrology. Sir has lots of peer review papers on his name. Without much delay, requesting Sir to take over the session, and over to you, Sir.
Thank you, ma'am, for that kind introduction. Let me just start. Is my screen visible?
Yes, sir.
Yeah, so I try to keep it short. So I'll be talking about the sleep, stress, and hypertension, the unseen epidemic. So this is the basic outline of stuff. First I start sleep, then we go about stress, and then just a few tips on management. So first, the effect of sleep on hypertension. So if we see a sleep or deficit occurs in almost 1/3 of the adults who sleep less than 7 hours per night, and I think being healthcare professionals, all of us have the issues with sleep disturbances. So it can be either because of unhealthy sleep behavior or circadian disruption because of shift work, especially with working night shifts or across the shift, and sleep disorders. Since the topic of sleep disorders is too wide, I will restrict myself to the duration of sleep and the shift work. So this has been proven in multiple studies that that AHA issued a scientific statement stating that short sleep duration, or it was different definitions were used of less than 5, less than 6, or less than 7 hours per night is a risk factor, established risk factor for hypertension. And there was another study in which they showed that for every 1 hour reduction in sleep, there was a 10% increase in cardiovascular mortality. So that's a very significant effect which we often neglect. If we go to the sleep duration, these two are the major studies which had evaluated the effect of sleep duration in hypertension, the LIM study and the PISA study. They found that if the sleep was less than 7 hours, there was significant increase in systolic blood pressure of about 5 to 13 mmHg. And it affected both daytime as well as nocturnal BP. And also on the day following the night shift, whenever there was sleep disturbance, the day following that also the BP tended to be higher. So not only on that day, the next day also the BP was seen to be higher. This is from the LIM study and this on the PISA study. You can see the significant increase the people who have a short sleep compared to normal sleep. So you have a significant increase in systolic BP and diastolic BP, and it is both daytime and nocturnal BP as well. So there's decrease in nocturnal dipping also apart from that. The significant effect of sleep restriction on hypertension. This is the trend which they show in the LIM and PISA study. They found the linear relationship between the duration of sleep and the mean 24-hour systolic BP. So both the systolic and both sleep duration. The thing is, this was the LIM study, but again there was one more study where this was published in Nature, which showed there was a U-shaped relationship between sleep and hypertension. So not only decreased sleep, even increased sleep had high chance of developing hypertension. So the actual prescribed is about 7 hours, 6 to 8 hours is the base cutoff. As we go below 6, the hypertension risk increases, and as we go above 8 and above, the hypertension risk increases. It's the same with both sleep and both for systolic and diastolic BP. These are the beta estimates, which is essentially the logarithmic value of the odds ratio. So then the sleep restriction. So once these observation studies were done, and they went on to go do a interventional randomized trials to see if actually there was any, or if it was just a hypothesis or it was any causal effect. So they found that if there was a 24-hour shift where the sleep duration was less than 3 hours, there was significant increase in both systolic and diastolic BP, almost 6 millimeters increase in both systolic and diastolic. Now 6 mm of diastolic significantly high compared to 6 mm of systolic. And one more RCT was around 45 people, mean age of 30 years. So again, they did sleep restriction of about only 4 hours of sleep was allowed per night for 3 days. Followed by that, they were allowed to have a recovery for another 4 days. These people were compared with controls who had a sleep of 8 hours per night continuously. They found that the restriction decreased the BP dipping even during the recovery phase, even after sleep, when they had this recovery period of 4 days, even then the nocturnal dipping had come down. So it's not like we have a sleep restriction and we are going to catch up the sleep the next day or day after. Despite that, the BP elevations persist. Then they did again crossover trial in premenopausal women. This was in high-risk patients, like overweight and obese patients, where they just reduced the person's individual's normal sleep time by 1.5 hours. They did not have fixed criteria. Whatever duration of sleep the person was taking, they reduced that duration of sleep by 1.5 hours. And they compared with 6 weeks, over 6 weeks, and they compared with people who were having normal sleep. Again, they crossed over after 6 weeks of washout. They found that the systolic BP, diastolic BP, awake BP, and MAP all were higher after sleep restriction. And contrary, previously we believed that sleep restriction can cause some psychological distress and that can contribute to hypertension. But in this case, they found that the psychological variables were not the mediators for association between sleep restriction and BP. So it had individual effect irrespective of the psychological disturbances. Then if you come to gender, again, most of the studies show that women, especially young women, have more effect of sleep restriction on hypertension. The exact mechanisms are not understood. One thing could be progesterone deficiencies. Estrogen has not been shown to be too deficient, but estrogen supplementation has shown some benefit. And one more major effect could be the muscle sympathetic nervous activity. They found that the sympathetic neuron activity within the muscles was significantly higher in women who had sleep restriction compared to men. So among women, again, if less than 5 hours, in one study had a 36% higher of hypertension. Same thing in another study showed almost 70%, almost double the risk of hypertension. In this study, they found no effect in men. So especially young women, we had to be more careful. Again, same thing was confirmed in Western New York study, where found there was 3-fold higher odds for hypertension in women with the short sleep. But following this, there were a few studies, again, which did not show a significant difference, but there is a physiological explanation with respect to the sympathetic activation and progesterone. So which may suggest that young women have a more effect of sleep restriction on hypertension. Then the shift work. Most of the healthcare workers, we are used to the shift works. It is significantly associated with CVD morbidity and mortality. The risk is about 30 to 35% increased risk of hypertension. And the BP control in patients who are already hypertensive, they found that the BP control was less in patients who are doing night shifts compared to those who are doing day shifts. Whether this is just because of impact of night shift or whether it has an effect on the medication adherence is not yet sure. So it could be either medication adherence because of night shift that very delayed in taking or maybe skipping of dosages, or whether night shift per se is affecting the circadian rhythm and hampering the BP control. This has to be studied. And the study was done in Brazil among female nurses. There again, they found that among night shift workers who had done night shift for at least 1 week, they had 68% high odds of developing hypertension, very significant number. The same thing we can see this is the control group and NS is the night shift group. So you can see the diastolic BP side change in night shift group compared to control group. This recovery phase, even the recovery phase, if you see this, the diastolic BP, it is higher in night shifts. But even during the recovery, the day after the night shift, when the person is taking rest, even on that day, even on the day of recovery, the diastolic BP is higher than the control group. So and even the BP dipping, you can see almost there is no dip. It's almost zero. So there is no BP dip in people who are in night shift, and also people who are recover on the day of recovery following the night shift. So it's not just that we do a night shift and we sleep the next day, that does not help. Even the day following that when they're taking rest, even then the BP dipping was significantly hampered. So this will again increase the hypertension and cardiovascular mortality. So how about non-shift napping? So since we saw that shift does affect, so is there any benefit of having short naps during the shifts? So they have studied different times of short napping. We suppose people are doing 8 to 10 hours of shift, 8 to 12 hours of shift, napping for 30. They have studied from different times from 20 minutes to 1.5 hours. And they found that nappers had a low risk of hypertension. Of course, but compared to day workers, they had higher risk of hypertension compared to people who are doing day shifts. But if you compare only people who are doing night shift, those who had some nap had low risk of hypertension compared to those who naps, almost 25% reduction in risk. So it may be predictive for hypertension. This was more predominant in people who already had insomnia. So this protective role could be related to melatonin secretion or BP dipping patterns in people who had on-shift napping. So we saw nap is protective. Then what about daytime napping? No nap is very common, especially in our part of the world. So if you already have adequate 7 hours of sleep at night, and you are having additional noon nap in the afternoon, most of the studies have shown increased risk of cardiovascular mortality and hypertension. You can see increased risk of hypertension, almost 50% increased risk of hypertension, increased of stroke, ischemic stroke. So noon naps increase, and you can this for 1 unit. So it's never, sometimes so just for 1 unit increase, there was almost 40% increase of hypertension. This is if you are having a normal night sleep, yes, you are having additional noon nap. So what are the potential mechanisms where this sleep can be associated with hypertension? One thing is the OSA, the obstructive sleep disorders. Apart from that, the short sleep deviation itself we cause hormone imbalance. So you have a increased gain and decreased leptin. This will increase the appetite and food intake that will contribute to obesity and metabolic syndrome. And again, it leads to physical activity and the behavior patterns and the circadian misalignment. So all these things contribute to metabolic syndrome and type 2 diabetes. And also this circadian misalignment, where circadian clock changes, that causes inflammation, oxidative stress, and in all these three together, we predispose the person to develop hypertension. Same thing with shift works. When you're having shift work, night shift, you don't sleep 6 hours in the morning, but you're doing night shift, you have a disturbed circadian rhythm. So again, there is decrease in melatonin and cortisol, increase in inflammatory markers. So this contribute to atherosclerosis, dyslipidemia, hyperglycemia, metabolic syndrome, depression, anxiety, and again, all these things will eventually progress to give rise to hypertension. Then coming to the genetic factors, there are something called as clock genes. There are different versions of clock genes. These are present the central clock, which is usually located in suprachiasmatic nucleus of hypothalamus. This normally interacts with the peripheral clocks present across the body, mainly in the brain, kidney, heart, and vasculature. These interact to produce BP. They control the post-translational modifications, translations, transcriptions, everything is controlled. They control various intestinal processes, and these are affected by the external stimuli, like light, temperature, humidity, feeding temperature. That's why the day-night difference becomes very important here. Because this nighttime, this goes into suppression, so that controls that causes nighttime dipping. So this is very important. So many genes have been found. One is the clock genes, then you have the BMR gene, you have the period genes, and you have the cryptogram. All these are associated with the circadian rhythm in BP regulation. So the BMI1 gene, if the knockout mice, they had a loss of circadian rhythm of BP, so more loss of nocturnal dipping and predisposing for hypertension. Cryptogram gene as was associated with hypertensive phenotype. So this was the induced, but in humans, they found that when there was sleep deprivation, even for couple of days, that had changes in gene expression of period 1 and period 2. Now, even one night of sleep deprivation lead to suppression of BMR1. So this again inhibits the suppression of BMR1. There's loss of circadian rhythm of BP. And apart from that, hypoxia-inducible factor, this is a more common in OSA due to the hypoxic episode during sleep. HIF1 alpha is stimulated. This again has an effects on periodic 1, cryptogram, BMR, and clock genes. So if you can see these genes, you can see all of it is just one night sleep deprivation. You can see all of them, all these genes have a significant increase in transcription after one night of sleep deprivation. However, it was not transferred into the inflammatory mediators as say, but I think this was because of only a short duration. There's only 1 to 2 nights of sleep deprivation. If you do longer studies, maybe we can have a more effect on inflammatory mediators. So coming to the effect of stress on hypertension. So it can cause variations to stimulation of nervous system and the vasoconstrictors. This eventually has effect on endothelial function, inflammation, immune function. White coat hypertension is one thing which we commonly seen, but apart from that, we have job stress, emotional stress, multiple stresses. So first let us go into the daily stress pattern. So this is one study where they saw the demand and resource ratio. The demand and resource ratio, suppose I have a work demand and I have the adequate resources to meet the demand. So that demand resource ratio, if that is equal, you can see if the demand is resource ratio, that is there is more demand, but reduction in resources. If the ratio goes up, there is increased risk of increased hypertension, increased blood pressures. Same thing with demands. If demands go up, increased blood pressure. If resources increase, there is decrease in BP. It's across systolic blood pressure, diastolic blood pressure, and also the heart rate. So this again tests the stress which is just not the demands, but also the resources available to us. We also influence our blood pressure patterns. Then emotional stress. For emotional stress, we have 4 phenotypes. Depends on the variance and arousal. Variance is how happy or how
Excuse me, sir. Last minute left.
Yeah. Okay. So there's emotional stress and also the arousals. Based on this, they saw if people have high arousal, high chance of hypertension. Same thing again, the mental stress, increased SPP, increased dietary pressure with increased heart rate. Work stress is one thing, white coat hypertension we are commonly seen, but I think it's time we start screening them at work also. We do home BP monitoring, but we'll stop doing work BP monitoring. So these patients could be missed if we don't do work BP monitoring. The same thing, the double product, they say that with this is effect of Monday blues. The Monday morning, they found that there's significant increased double product, heart rate into SBP, which has increased cardiovascular risk. So mechanisms, again, the chronic stress causes nervous system stimulation, increased cortisol, RAS activation, again, inflammatory mediators causing energy injury and vasomotor activity. This eventually leads to the phenotype of hypertension. Same thing, acute stress is predominantly mediated by SNS activation, whereas chronic stress predominantly through cortisol mediated. Here there is no increase in cardiac output, but here there is increase in cardiac output. Here there is cardiac output normal, but peripheral vasculature increases. So just a few things about sleep hygiene, the 10-3-2-1 rule. I think most of us don't follow this. 10 hours before bed, no caffeine. 3 hours before bed, avoid food. 2 hours before bed, stop working. And no screens. 1 hour before bed, start relaxing and screen-free exercises. And 0 hours is do not snooze in the morning when your alarm goes up. Maintain the consistency. The one tip on stress reduction, get enough sleep, relaxation techniques, social network is very important, and time management skills. Any stressful situations, try to resolve them by yourself or take help. Nurture yourself, take care of yourself, and always never hesitate to ask for help. Thank you. And
Thank you so much, sir, for explaining the emotional states and especially sleep hygiene. As you rightly said, we all know, but none of us follow the same. We all will try to follow. And thank you so much for the wonderful session. Without much delay, I would like to move to our next session. I would like to invite Dr. Subharti Kar. Sir is an associate professor at the Department of Nephrology at Habiganj Medical College, Bangladesh. Sir has been actively involved with a lot of associations. He is fellow at the International Society of Nephrology, ISN. He is also a member of South Asia Regional Board, International Society of Nephrology. He is a member at IASN Education Social Media Team. He is also scientific secretary at Bangladesh Renal Association. He is member of Bangladesh Society of Organ Transplantation. He is a member Bangladesh Society of Peritoneal Dialysis. He is also member at ISH. He is member editorial board at Bangladesh Renal Journal. A part of this, sir has a lot of work on the oral presentation and the poster presentation as well. I would like to invite sir once again, and over to you, sir.
Thank you. Can you see my slides?
Yes, sir, we can see a slide, but it's not clear. I can see a lot of windows there.
I suggest to switch to PowerPoint. So open the PowerPoint.
Yes, sir, it's visible now. Yeah, it's clear. Yeah.
Full screen. Yeah. Thank you so much for your kind introduction. My topic is on breaking the sedentary trap, making physical activity possible for all. So hypertension, as we all know, the leading preventable risk factor for cardiovascular disease and premature death worldwide. Physical inactivity, on the other hand, is a major contributor for ailing obesity, diabetes, hypertension, other NCDs. LMICs like Bangladesh, India, Pakistan are experiencing a rapid rise due to urbanization and lifestyle changes. And most NCD cases remain undiagnosed because all of them are silent killer. And addressing lifestyle, particularly increasing physical activity, offers a low-cost, high-impact solution. That is, physical activity is inexpensive. It does not cost money, so our patient can easily afford it if they are motivated. So hypertension is a major global health challenge responsible for 7.5 million deaths annually and affecting an estimated 1.4 billion individuals aged 30 to 80. And on the other hand, physical inactivity, nearly 1.8 billion adults at risk of disease from not doing enough physical activity. Low and middle income countries like ours, that is Bangladesh, India, Pakistan, Afghanistan, we have common things in common challenges. That is that, say, as a nephrologist, I can tell that in Bangladesh, India, Pakistan, 70 to 80% of end-stage kidney disease patients cannot afford dialysis or transplantation. So we have things in common and we have challenges in common. So we have higher burden of NCD diseases, and targeted interventions in these regions are essential for advancing global health equity. This is a big trial done on the adolescents on physical activity levels, and you can see that the physical activity levels among the boys and girls under 18, you can say never do any physical activity in a week, is 3.3 in Central and Eastern Europe, 19 in Central Asia, and it is much higher, that is 35.1% in South Asia. On the other hand, girls never do any physical activity in a week is 4.5% in Central and Eastern Europe and 37% in South Asia. There is highest level of physical inactivity in South Asia. Probably lack of awareness, lack of infrastructure, lack of resource, lack of information pose this population to a state of physical inactivity. So what about the physical inactivity level of Bangladesh, India, Pakistan? Bangladesh tops high. There are three different data. Bangladesh tops by 56% and lowest is in 46% in Pakistan, and 49.4% of people in India are physically active. So what is sedentary lifestyle? Sedentary lifestyles are increasingly common and now represent a major public health issues, contribute significantly to disease risk and mortality in many countries, including South Asian countries. So characteristics of a sedentary lifestyle: not participating in physical activity or too passive in their life, too much time watching TV, mobile phone, playing video games or on the computer, not doing enough activity, driving or using public transportation a lot and rarely walking or cycling, spending a lot of time sitting at work, school, college or at home, not having hobbies or interest. We see nowadays with physically active elements such as sports or outdoor pursuits. So sedentary lifestyle can cause cardiovascular disease to obesity, from poor quality of life to diabetes, frailty, etc. So screen time replaces physical activity, modern lifestyles impact activity levels, and urbanization reduces physical activity opportunity. These are the sedentary traps nowadays in our society. Bangladesh, India, Pakistan, we all have we have done much success in preventing preventable infections by our EPI program, immunization program. But nowadays, NCD has become a big challenge. We didn't have any NCD department in our directorate 12 years back. Our government has been aware that NCD is a big issue, and NCD are responsible for 67% of all deaths in Bangladesh, highlighting a significant public health issue. Among these, hypertension and physical inactivity are prevalent, contributing to the global health burden faced by this population. So we all know that physical activity can prevent chronic disease like heart disease, diabetes, many types of cancer, even dementia, depression, anxiety. Everyone can get benefit from physical activity. Age, ethnicity, shape, and body size does not matter to do physical activities. Lifestyle influencer of hypertension, we can tell our patient to reduce alcohol intake, salt intake, quit cigarette smoking, do more physical activity, and change dietary patterns, as our prior speaker told. So this is a very interesting trial, very recent trial as well, that is the first time dose-dependent effects of aerobic exercise was seen by the authors. It was published in Hypertension Research 2024, and it showed that only 30 minutes per week aerobic exercise can reduce 1.78 millimeter of mercury of systolic BP, 1.23 millimeter mercury of diastolic BP, 1.37 millimeter mercury of mean arterial pressure, and 1.08 beats per minute of resting heart rate. This also suggests that highest 150 minute per week is advisable, and more than their findings show that more than 150 minutes per week may not do much good to the health of the human being. This is the summary for the children, children for and as adolescent age 5 to 7 years. They recommend that children and adolescents should do at least an average of 60 minutes per day of moderate to vigorous intensity exercise, mostly aerobic physical activity across the week. Vigorous intensity aerobic activities as well as those that strengthen muscle and bone should be incorporated at least 3 days a week. Similar data also supported by American Health Association. They tell that get at least 150 minutes per week of moderate intensity aerobic exercise or 75 minutes per week of vigorous aerobic activity or combination of both. Spend less time sitting. Even light intensity and activity can offset some of the risk of being sedentary. Gain even more benefits by being active at least 300 minutes per week. Increase amount and intensity gradually over time. Same go for ADA guideline 25, moderate intensity physical activity like brisk walking at least 150 minutes per week, improves sensitivity and reduces abdominal fat in children and young adults. Physical activity lowers the risk of developing type 2 diabetes and enhances cardiovascular health. Extended periods of sedentary behavior may increase diabetes risk, even among those who engage in higher levels of physical activity. Physical activity also appears to help prevent gestational diabetes mellitus. So some of the common barriers to physical activity, psychological barriers, patient or pupil may not get motivated to do physical activity, may be fearful, may dislike gym, not being of sporty type of personality. Physical barriers, the aging process, fatigue and weight gain. Employment may not allow him to much time to do physical activity. Seasonal weather may be bad for a long period of time to do physical activity. So these are the common barriers. So barriers of physical activity in rural Bangladesh, we have seen that the introduction of machinery in agriculture in rural area reduces the physical demands of workers, leading to a decline in daily physical activity levels. So the farmers and the rural people also has become less physically active nowadays, and migration of the people to urban areas for better job opportunities results in a loss of the physically active lifestyle typically associated with rural living. So in low and middle income countries like ours, gender issue is a big issue. Safety issue is a big issue. Safety issues such as harassment, violence, and poor infrastructure often prevent women, children, and the elderly from engaging outdoor physical activities. So this is a challenge, area of challenge to overcome by our countries. So identifying gaps in the healthcare system, limited counseling on physical activity. The healthcare system in Bangladesh often overlooks the integration of physical activity, counseling into routine patient care, which is crucial for management of NCDs. Lack of integration in treatment protocols. Physical activity is often not included in treatment guidelines or standard care protocols, resulting in missed opportunities for preventive care and rehabilitation. This is an article in the BMJ Open suggested for the physicians in the United Kingdom, a kickstart patient movement, a 5-step framework for primary care clinicians to support inactive patients in becoming more active. The outlines are assess the patient's readiness to change their current physical activity levels, screen for relevant risk factors and contraindications, use key principles to agree a tailored program, give advice to reduce sedentary behavior, and arrange a follow-up consultation. Solutions also we suggest walking is a simple equipment-free form. We should make them understand physical activity that can be easily integrated into daily routines, promoting safe walking and encourage good, healthy, physically active lifestyles. Cycling supports heart health and offers a practical commuting option. Infrastructure like bike lanes are lacking in our cities, can promote active transport by the cyclers. So effective community-based interventions for promoting physical activity. Walking group fosters community. Walking groups create a supportive environment, encouraging regular physical activity among members while fostering community ties. Fitness programs in mosques and clubs. Fitness programs held in mosques and clubs can integrate physical activity into social gathering, making exercise accessible and culturally relevant. Tailored community-based initiatives can be tailored to local preferences and resources, ensuring higher participation and effectiveness in promoting physical activity. Policy recommendations for infrastructure improvement. You can see the middle picture in the left. Dhaka footpath is occupied by the motorbikers during a period of traffic jam. So we need an improved footpath. The development of footpaths is essential to ensure safe walking routes, encouraging more people to engage in physical activities like walking and jogging. Dedicated cycling lanes. We can see in the Europe that there is dedicated cycling lanes, but we lack this. Dedicated cycling lanes can promote cycling as a viable mode of transportation, reducing reliance on more motor vehicles and contributing to public health. Creation of safe parks. Safe parks offer recreational spaces for families and individuals, enhancing community engagement and providing safe environments for physical activities. So these are our country initiatives. In Bangladesh, there are 64 districts, and our government has appointed 64 district sports officers. Physical activity is a mandatory part of under school education curriculum in Bangladesh. The rights and protection of persons with disabilities was developed to ensure the people with disabilities are included in all spheres of society. Dhaka Transport Coordination Authority has drafted a regulation for pedestrian safety to ensure safe walking environment for people in and around the urban areas of Dhaka city. Our High Court ordered the government to prohibit vehicles, especially motorbikes, from straying into walkways and footpaths in the capital city. So now I am at the end. My take-home message is hypertension and physical inactivity are silent killers, fueling early deaths worldwide. Regular physical activity can prevent and control hypertension, reducing cardiovascular disease burden. In Bangladesh and countries like ours, urbanization, lack of awareness, and limited public spaces worsen the sedentary lifestyle crisis. Promoting affordable community-based exercise and lifestyle awareness is key to reducing national health costs. Thank you so much for your patient hearing.
Thank you, sir, for concluding the session and giving the important messages. Now we have few questions in the question answer box. The first question is, I think, for Dr. Varun. Women after 45 plus do experience a reduction in sleep hours. What are the best ways to cure the sleeplessness in this age group?
Ma'am, that depends on the cause. First thing is the sleep hygiene has to be maintained. if you are using the most common mistakes I've seen is the food intake. At least we have to maintain a 3 hours gap between food intake and sleep, and the usage of mobiles and electronics. That is one thing. And second thing, it depends on the insomnia, depends on the stage of sleep. We have the sleep, it depends on if we have 4 to 5 hours of sleep, I think that is just a GABA based. So we decide whether the problem is with the GABA based system or the acetylcholine based system. Based on that, we have to decide on the drugs which we need. It's a pharmacotherapy. But what we can control is the 10-3-2-1-0 rule. If you control that and stay, if you are having insomnia, then we can start on medications.
Okay, thank you, sir. Moving to the next question, I think it goes to Dr. Mansi Patil. Will the turmeric or pepper gives the same effect as of curcumin or piperine? If so, how much quantity of turmeric and pepper needs to be consumed?
I think that's a fantastic question. So, for those who are not from a nutrition background, just to clarify, turmeric is the spice that we use in cooking, whereas curcumin is the main active compound that we have in turmeric. Black pepper similarly, black pepper contains piperine, which is helpful in increasing the curcumin absorption. So there are studies which say almost, adding curcumin and black pepper will increase the bioavailability by almost 20 times. Now, the challenge is the turmeric powder that we have, which is which we use in cooking, that has a curcumin level of just about 2 to 5%. Now, the doses that have been advised are almost 500 to 2000 milligram per day of curcumin, which means to achieve that, we need to consume 10 to 40 grams of turmeric powder daily, which is really not practical. What we consume is maybe 5 to 10 grams per day, which amounts to somewhere around 3 to 5 grams of curcumin. Honestly, if you look at the supplementation, so the supplements will have almost 25% of curcuminoids, and that translates to almost 1000 to 2000 milligrams of curcumin that is required as per the studies. Now, therapeutically speaking, supplements have a better reliability and they deliver the therapeutic dose that we are looking at. But for a general health advice, I'd still say maybe just 1 to 2 grams of 1 to 2 teaspoons of turmeric powder with a pinch of black pepper is good enough, which will give us maybe 40 to 200 milligrams of curcumin. It is not therapeutic, but potentially beneficial for long term. But if you're looking at a therapeutic effect, that is when supplementation comes into picture, and we may need to then give the 1000 milligram per day, which is standardized to 95% curcuminoids, and piperine is generally added to this supplementation already. So that is something that can probably be given. I hope that answers the question.
Yeah, thank you so much, Mansi, for very good clarity on the question asked and with the grams and dosages. There are a few questions I see on the diet therapy and also the spices. I would request all those contestants to please continue attending our web series as all those topics are going to be covered. There is one question. Is there any significant role of salt restriction in PIH? Any of the speakers can take this.
Dr. Azra, if you'd like to address that question.
Yeah, I think for PIH, really the same guidelines apply as essential hypertension. So in PIH, obviously these people are prone to develop hypertension during pregnancy. So we are dealing with a lot of other mechanisms. But the recommendations are to have a DASH type of diet. So you're talking about high intake of fruits, vegetables, avoid sugar and salt, because you're also looking at insulin resistance as one of the causative mechanisms in PIH. So that's going to be a problem as well. So if they can maintain a good DASH diet, that will really suffice. There are no other particular recommendations in terms of spices or anything else. So I think the salt restriction obviously is important. But I just wanted to add a little bit about Mansi's talk on salt and spices. And I think a lot of people are asking about spices. And this brings me to the idea that, especially in our part of the world, and also it pertains to the West as well, people are generally very interested in herbal cures, right? Anything which is not an allopathic medicine. Most of the studies have been done, whether it's curcumin or garlic and many other studies, they have a lot of confounding variables. So I think it's very important while we advocate using those particular herbs, which have definitely a lot of medicinal effects as adjuncts, but not as sole mechanisms to reduce blood pressure. Because the worry in many of our patients, because of lack of awareness, they would like to discontinue their regular therapy or particular lifestyle recommendations, which are given by guidelines, right? So the mainstream, even that even potassium supplements are not a class 1 recommendation yet. So I think we just have to advocate them as adjuncts rather than as therapeutic. And I think, Mansi, you probably made that point clear. But I just wanted to kind of reinforce that. We don't have people strictly focusing on those for reducing blood pressure. Thank you.
Thank you so much, Dr. Azra. And now, as we are towards the end of the session, so I would like to thank all the respected speakers, Dr. Azra, Dr. Varun, Dr. Kar, Dr. Mansi Patil, and all the IPIN India staff technical team who has helped us, and also all the participants who has attended the session. And I invite you all once again to our next series of the hypertension webinars. Looking forward to join you all once again. Thank you so much.
Before we log off, Swati, if you could change the slide once more back to the membership slide for ISH. So we invite all of you to please take up the IAPN and the ISH membership. So ISH membership for associates is free. So anyone who's just interested in hypertension, you'll keep getting the regular updates. It'll be fantastic. You simply have to scan the QR code and submit your membership application. It'll be a pleasure to have you all on board for this this campaign that we've started for hypertension, and to try and get it under control, not just in South Asia and Central Asia region, but across the world. So please, if you're not able to scan, take a photograph, and if you're not able to do that as well, let us know, and we'll send across the details for the membership for both ISH and IAP in India. Thank you, Datta, for moderating this session wonderfully. And thank you for all the ISET Saka region members to contribute to this webinar. And looking forward to meeting you all again tomorrow. Thank you and have a great day. Bye.
Thank you.
Thank you, Mansi.
Thank you.